Hello everybody, Dr. A with your lesson on Chapter 8 of the U.S. healthcare system. We're going to talk about healthcare payers and financing. Okay, so we're going to look at different cost sharing strategies and health insurance plans. We're going to discuss the importance of Medicare and Medicaid to healthcare, and we're going to look at PACE and TRICARE and the Children's Health Insurance Program, all important to healthcare. And then your homework is on the ACA, the Affordable Care Act. All right, so unlike countries that have universal health care systems, payment of healthcare services in the U.S. is a mix of out-of-pocket payments for patients who pay entirely or partially for the services rendered. So if you have a copay, for example, that would be a part of an out-of-pocket, or if you're responsible for 20%, or if you have to meet a deductible, that would be an out-of-pocket. And then also if you're not covered and you're just paying straight cash for your services. Then you have health insurance plans, and those are indemnity plans or managed care organizations. So there you have health insurance coverage and you get reimbursed, or well, sometimes you can get reimbursed, or you can the clinic files for the reimbursement with a health insurance plan, and then you pay the difference of whatever you owe. Of course, then there's public and government funding, so these are all the programs that are government-based, like Medicare and Medicaid, but also the children insurance plan and all of that. And then health savings accounts. So we'll discuss a little more in detail about health savings accounts. So these are really savings account where money is deposited into it, usually by a mix of the employer and the employee, and those can only be used for health expenses. All right, so let's start with health insurance. It is a major component of, it's one of the bigger payers for the healthcare services. So it is a financing mechanism that protects the insured from using their personal funds when expensive care is needed. And that's really the idea of health insurance. If you want to correlate it to car insurance, you carry car insurance in case, in case you total your car or have major damage or total somebody else's car, and they could sue you and that kind of stuff. It can be very expensive. And so that's why you carry car insurance. And health insurance is kind of the same way. And so even like with car insurance, sometimes if it's just a little fender bender or something that's just minor, you may not want to file, because it would be worth filing in your car insurance for reimbursement. So you may just decide to just fix it yourself, or just leave your bumper messed up or something like that, right? And so with health insurance too, sometimes small stuff is, may not be worth filing, if it's really meant for expensive care. But now we have plans that cover all kinds of stuff. So if you have health insurance, it will decrease the risk of delays in seeking treatment that might result in increased costs. Meaning that if you have health insurance, you're more likely to go see the doctor when a problem arises versus waiting, hoping it goes away, hoping you'll get better, and then waiting for you to get really, really sick and then end up going to the ER, might require hospitalization, and in the end it costs you more than if you were able to get care earlier on. The main source of health insurance is employer-provided health insurance, and they're all the primary source of payment of healthcare services in the U.S. But employer-provided health insurance has become very expensive for businesses, and that results in the increase in cost sharing by employees, meaning that they're having to pass some of these costs on to their employees, and their employees' premiums for their health insurance is all going up. What some of the things that you probably need to understand too, and this happens not only in the U.S. but also in Europe, is that sometimes companies will then move out of the U.S. or move out of Europe and go into poorer countries because to move their manufacturing facilities and plants, because those places don't have requirements for health insurance and all that kind of stuff, and then it's cheaper, the employees are cheaper, and therefore cheaper labor, and so cheaper to produce the product. Okay, so let's look at a few health insurance terms. So group insurance anticipates that a large group of individuals will purchase insurance through their employer, and the risk is spread among those paying individuals. So that would be like if you work for a big company. So like here, if you work for a state, we have group insurance, and everybody that works for a state that's covered pays into the system, and then into the health insurance, into this account, and out of that account, all the health expenses are paid according to the rules of the plan and all of that. And so it's usually for big companies, manufacturing companies, hospitals would have group insurance and that kind of stuff for their employees. Self-employed individuals can purchase individual private health insurance. And this is where there was a hole before the Affordable Care Act, where it was really expensive to get private insurance. And so a lot of times if you were self-employed, you just didn't have any health coverage, or you hoped that you had a spouse that was working for an employer that offered group insurance where you could be covered through your spouse and have health insurance there. And so, but now we have the health insurance marketplace where a lot of self-employed individuals basically they're banding up and forming their own group insurance instead of it being administered through a big company. Self-funded or self-insurance programs are health insurance programs that are implemented and controlled by the company itself. So in a way, a state's health insurance is self-funded because, again, we all as employees pay into it, and a state pays into it, and all of that, and then all of those premiums that are collected go into a big pot, and everything's paid out of that, and we get to set our own rules and all that. But actually, we hire a company to manage it, like Blue Cross Blue Shield or Cigna or something like that, process the claims and do all that. Okay, so I'm going to show you the benefit rates for the ASU plan. So if you're on your Nearpod, you can click that. And so who would pay the bulk of the premium costs there? And so let me open that real quick here for you. But click on that if you're on your Nearpod. Give me just a second. This thing is going to take a minute to pop up. And here we are. And so I'm going to move the window slightly here for just a minute. And so you can see, for example, here, I'm going to move my screen. So if you had 24 pay periods a year, so paid every 2 weeks, employee only, the total cost of health coverage is $287. ASU would pay $239, and the employee would pay $48. So you can see, obviously, the employer usually bears the brunt of the cost for the health premiums. Okay, so let me readjust this. There we go. Okay, and then again, looking at the same document, when you look at it, which plan do you think would make the most sense for a new college grad? So again, you can click on it, download it again. All right, so managed care plans are a type of health program that combines administrative costs and service costs for cost control. So they're usually like big plans with lots of hospitals involved in it and all of that. And their terms are slightly different than those of your regular health insurance plans. All insurance plans fall into 3 categories. They're either voluntary health insurance, social insurance, or public welfare insurance. So we're going to look at each of these. Okay, so voluntary health insurance is a type of private health insurance provided by nonprofit and for-profit health plans such as Blue Cross Blue Shield. So if you have an employer-sponsored health coverage, it's a voluntary health insurance. Okay, because you can select to get health coverage or not. So that's where it's voluntary. Okay, they offer it to you, but you're not obligated to purchase it. All right, social insurance is provided by government at all levels, federal, state, and local, and an example would be Medicare. So it is an entitlement program, meaning people pay into it through payroll taxes all of their lives, and then when they get, usually now it's 66, so it's a retirement age, then they can be covered by Medicare after paying into it their whole lives. And then public welfare insurance is based on financial need and not entitlement, and Medicaid is an example. And so for public welfare insurance, there's usually an income threshold that has to be met, so you have to be below a certain income. Okay, so let's talk about payment terms. So there are 2 forms of payment that health insurance will do. There's the fee-for-service and the prepayments. And so the fee-for-service is you go and get a checkup or get a test for coronavirus or the flu or whatever, and you get the service, they file your health insurance, and your health insurance pays for the service that you got, okay? And then if you had a copay or whatever, you pay for it, okay? Prepayment is a little bit different. So usually that one's a little bit more like a form of managed care, where your let's say your clinic, your provider is paid X amount of dollars a month for your care all year round, as long as you have that health plan. And out of that, they have to manage your care. And so if you don't use that much, then they get to keep it. But if you use more than that, then it's on them. So, but, and usually what it is within the whole group of the people that are taken, it evens out, even if some use more and others use less. Usually the clinics don't lose money. They should at least break even. But it incentivizes them to manage their patient population really well and effectively. And so those are the basis for all insurance coverage. Okay, so again, fee-for-service was developed, for example, by Blue Cross Blue Shield. It's based on the concept of a person purchasing coverage for certain benefits, using the health insurance coverage for these designated benefits, and then paying the provider for the services provided. And there's two ways to do this. We do the thing where the provider may be paid by the insurance. So your clinic has your insurance information, files for reimbursement by the insurance, and then you have maybe a little bit of out-of-pocket to pay, and then the insurance pays the clinic directly for what they owe them. But the provider could also be paid out of pocket by the patient. So there's a possibility too that what you can do is you go to the clinic, you pay the entirety of the bill, and then you file for reimbursement to the insurance, and the insurance pays you back on the cost that, whatever you qualify for. It's kind of honoring. Most people choose to have the clinic to file to the health insurance. It's just less hassle. So again, in the prepayment concept, the individual pays a fixed predetermined amount for the services rendered. So if you go to the doctor, it's $10, $15, $20, $30, something like that. And but the clinic also gets X amount from the insurance company a month, whatever, to take care of that patient population. So again, managed care usually use that prepayment type of model. Okay, so what are deductibles? So deductibles are payments that are required prior to the insurance starting to pay for services, and it's usually in a fee-for-service plan. So this will not be in a prepayment model. And so if you have a deductible, a lot of times it could be $500, $600, $1,000, or $1,500, usually meaning that unless it's just like an office visit or something that's specifically covered. So let's say you have an ER visit or a hospitalization. The first whatever your deductible is, so let's say your deductible is $1,000. The first $1,000 of costs are on you, and then after that, the plan pays. And usually it's something like once you've met your deductible, the plan pays 80%, you pay 20%. So then after that, for the remainder of the bill, you would owe 20% of what's left after you've paid your deductible. And the deductibles, you can accumulate. So let's say you have an injury and you have to go get an MRI, and you have to pay, and you haven't met your deductible, so you have to pay out of pocket, and so you pay $400 to go get an MRI. Well, that $400 applies towards your $1,000 deductible. And then MRI reveals that you have to have surgery, and then so the hospital may ask you for the rest of that, for that $600 going towards your deductible, to be applied towards the surgery, and at least that way you've met your deductible, and then they'll bill you for the rest of it. And so it's very possible that on the day when you go to surgery, they ask you, okay, you know, when you come to surgery, you need to pay the $600. That way you've met your deductible and stuff, and you know they have the money, and you've paid for that, you know, $600 worth of the care. Anyway, the deductible amounts will vary from individual and family health insurance coverage, and they do cover 1 calendar year, meaning start January 1st and end at the end of December. You'll see a trend where a lot of people, if they've met their deductible somewhere like halfway through the year or towards the end of the year, they may try to schedule more procedures because their deductible has been met, and they're like, oh, well, you know, I needed this done or I needed that done. Let me go ahead and try to get it in before the end of the year. The physician may or may not have an availability to do that. So in their example here, an individual may have a $250 deductible per calendar year, which means they must pay $250 worth of services before their health insurance covers the services. Family coverage will typically have higher deductibles, and there's also a thing with family coverage where there's also a family deductible. So let's say if your deductible was $1,000, your family deductible might be $2,000, and once your entire family has reach a $2,000 out-of-pocket cost that they've paid, then everybody is going to get reimbursed for any care 80%. So for the cares that you won't have to meet any more deductibles, basically. So so in this one, I'll go ahead and click on it again. You're going to click on this file here and download it, and which one has the highest should be deductible. I'll change that per individual. And if you give me a second, this file is going to pop in, maybe. Sorry, my internet's being slow. So again, I'm going to move it here slightly and move here. And so there are 3 plans here at ASU: Health Savings, Classic, and the Premier plan. And if you're in network, the deductible is in the health savings plan, it's high, it's $2,800 per individual and $5,600 per family, and the classic plan is $1,500 per individual and $3,000 for family, and in the premier plan is $1,000 per individual and $2,000 for the family. Now, of course, if you will guess, this one has the cheapest premiums, this one has the most expensive premiums. So that gives you kind of an idea of what's going on there. All right, fix this quick. All right, so that's deductibles. So comprehensive health insurance policies will have benefits that include things like outpatient and inpatient services, surgery, lab testing, medical equipment purchases. So if you need like oxygen or something like that, or you need a wheelchair, or you need a walker or something like that. Therapies such as like physical therapy, occupational therapy, and all that kind of stuff, and other services such as mental health, rehab, and prescription drugs. So that would be a comprehensive. So all your basic needs should be covered there. Major medical policies only reimburse hospital services such as surgeries and any expenses related to hospitalization. So with a major medical, they're always cheaper than a comprehensive health insurance policy. Basically, if you need to go see the doctor, the cost is going to be on you. To go to the clinic and all that kind of stuff, any kind of checkup, you have to pay for it. But if you get a major thing, so hospitalization, then you're covered under your major medical policy. Okay, so again, if you click on it, or the ASU health plans, you think comprehensive or major medical, you can click on the file and analyze that again. So a catastrophic health insurance policy covers unusual illnesses and it has a high deductible, and they have a lifetime reimbursement cap, so they cap their reimbursement at a thing. So a catastrophic is very similar to kind of a major medical, except the deductible is really high. So the deductible could be something like $5,000, and it is for something like really weird that happens. And so like a lot of times, before there was a health insurance marketplace, some people would take out catastrophic health insurance policy for really, it would be the premiums were low and stuff, and say, put some money in savings and all that, and then if you have this like weird cancer or brain tumor or something really weird, it comes when you're young and you were not expecting, these types of policy will pay. And some of these weird cancers and things that are unusual the bills can quickly get really high, in the hundreds of thousands of dollars, and the thing on there is like, if your deductible is $5,000, but well, that's pretty much all you're going to be out, is that really high deductible. So it could be worth it. But if you're banking on, you know, whether or not something it could be that you pay for it and you never use it also. There are also some specific health insurance policies that are disease-specific policies, for example, for cancer. So that's some of the AFLAC stuff for the cancer policies. And then you also have Medigap or Medicare supplemental, or also MedSup policies. And so these provide supplemental insurance coverage for your Medicare patients. And so just a little bit better coverage. Okay, so there are two basic types of insurance plans. There are indemnity and managed care. The indemnity is the same thing as a fee for service. So an indemnity plan is a contract between a beneficiary, so that's usually the employee, and a health plan, but there is no contract between the health plan and the provider. So they don't make you go see a specific provider, specific physician, or specific clinic or hospital or whatever. So you're covered by the health plan, but they don't dictate who you have to go see. The beneficiary pays a premium to the health plan, and when the beneficiary receives health care, the plan reimburses the beneficiary based on an established fee for a particular service, regardless of the provider's fees. So if the doctor bills the patient $100 for the visit, and the patient pays that $100, but the insurance plan says no, we only cover $50 for that, they'll reimburse them $50, and that's it. And so again, the beneficiary usually reimburses the provider directly, so, and then files for reimbursement from the health plan, but they can go see whoever they want. The managed care plans combine health services and health insurance functions to reduce costs. So employers can contract with a health plan for services on the behalf of their employees. The employer is required to pay a set amount per enrolled employee on a monthly basis, and it's usually to a certain managed care system, and you have to use if you want to have the benefits, you have to use the people that are contracted with a managed care organization. So again, the contracted health plan has a contract with certain providers to whom it pays that fixed rate per member on a monthly basis. So it's a per member per month for certain services, to cover services that are covered by the plan. And employees may cost share a co-payment, so maybe something like, okay, it's $10 for you to go see the doctor, but the clinic in the meantime is getting X amount of dollars per month for you, whether or not you use their services. And in managed care plans, there are no deductibles. Okay, poll question: is ASU's health plan an indemnity plan or a managed care plan? What do you think after looking at the file and the benefits? Answer that. Okay, so there's a trend in health insurance plan. This is called the consumer-driven health plans, and they're tax advantage plans with high deductibles. So these are tax advantage, meaning that if you pay into that, it takes that off of your income. It's like pre-tax payment, so it lowers your income on which you're taxed. Most common consumer driven health plans are health reimbursement arrangements, HRAs, or health savings accounts, which are HSAs. So your health reimbursement accounts or personal care accounts, they began in 2001. As a result of an IRS regulation. The HRA is funded by the employer but owned by the employee, and remains with the company if the employee leaves. So this has been an issue because it has no portability. So funded by the employer, it should say really owned by the employer, but anyway, you can't take it with you when you leave. So you can put, the employer puts money into it. As long as you work for that employer, you can use those funds to pay for health care, but once you leave the company, that money stays behind. Whereas the health savings account are fully portable. So again, it pairs a high deductible plan with a fully portable employee-owned tax-advantaged account. And so this one, if you leave the company, it goes with you, and the money that you've put into it can stay into it, or that that your previous employer put into it stays into it. So it encourages the consumers to become more cost-conscious when using the healthcare system, because you use your own funds for the healthcare services. And it's almost like, okay, you have X amount that's paid into this health savings account by your employer, and that's what you have. If you don't use it, it gets to sit in that account, and maybe you can use it the next year, or the next year, or the next year. And if you do use it, you have to manage it. And if you use up all that money, then you would have to pay out of your regular income the rest of the bills that you owe for healthcare. So again, the savings account is a portable account, which means it can be transferred to another employer when the employee changes jobs. So there's also flexible spending accounts and medical savings accounts. So flexible spending accounts provide employees the option of setting aside, again, pre-tax income to pay for out-of-pocket medical expenses. The drawback of the FSA is that the amount set aside must be spent within 1 year, and you have to decide how much you want. So basically what it is they take out of your own paycheck. You can say, okay, take $50 a paycheck, or that's $100 a month, so that would be $1,200 in a year out of my paycheck, and put it in my FSA, which means that to do it right, you should, during that year, you need to at least spend $1,200 on out-of-pocket stuff or health-related stuff, or you lose the money. So you need to kind of be able to forecast what you might need. So I tend to usually put less in there. And then you can use it for all kinds of stuff. So you can use it to pay your copay. You can use it to pay for medication. You can use it, you can even use it to buy vitamins and supplements and over-the-counter medications and things like that. You can use it to pay for eyeglasses or dental care or anything like that. Anything where you have to pay out of pocket, you can use this. But if what you pay into that flexible savings account for a year, for example, is like totals up to, let's say, $500, once you've used up $500 of those benefits, then it doesn't pay anymore. So anyway, but it's a good, and again, it's something that you don't have to pay taxes on, so that's it's pre-tax dollars, so it lowers the income on which you have to pay taxes on, which is good. Your medical savings account allow workers employed in firms that have 50 or fewer employees and also have high deductible health insurance plan to, again, set aside pre-tax dollars to be used for healthcare premiums and non-reimbursed healthcare expenses. So again, the MSA, there has to be a smaller type of company to use it. Okay, so next question here. An FSA can be used to pay for, and then you've got a list of choices, and make your choice and answer that in your little Nearpod. And then you have Samaritan Ministry. So in the 1980s, Ted Pittenger developed a healthcare sharing ministry, and when members need assistance, they receive support from other members. And members pay on a monthly share to other members in need. And so this is a model that has become more popular. And so to cover a family or to cover a person would be X amount per month, and you pay that in. And then if you have any kind of health, you go to the clinic or whatever, and you have a bill, you pay that bill, but then you file for reimbursement, and then they pay you back for that medical bill. That's the way it works, basically. I have a video here for you guys to watch on one such Samaritan ministry. And so again, those are in your Nearpod. The patient-centered medical home is a newer concept. So the American Academy of Pediatrics created this medical home concept in 1967. And it's involved now into simply patient-centeredness. So it's a coordinated care delivery through the primary care provider to ensure that all the necessary services are received and to have better, efficient care for the patients. The National Committee on Quality Assurance developed a patient-centered medical home evaluation model, and over 13,000 different practices have been recognized by the Quality Assurance organization, committee, and more than 100 payers have provided incentives to these programs. Again, it's just a coordinated care model. Okay, so the government health insurance program, so we have Medicare, Medicaid, PACE, CHIP, and workers' comp and TRICARE that we're going to talk about. So Medicare Part A is hospitalization insurance, so it only covers hospital bills. Everybody gets that has paid in gets Medicare Part A. And then everything else is supplemental, so they actually have to pay premiums to get the Part B, Part C, and Part D. And so it's X amount a month out of hopefully what they've put back for retirement. So Medicare Part B is a supplemental health plan to cover physician services, so your clinics, your doctor's visits. It is financed 24% from the enrollee, so from the senior that's enrolled in this, and 76% from federal treasury funds. Part C, Medicare Part C, is Medicare Advantage. It covers all the services in Parts A and Part B. It is voluntary. It is available when you enroll in Parts A and B, and it is basically a managed care for Medicare. So it's a more cost-effective health insurance program such as HMOs and PPOs, so health maintenance organizations or primary provider organizations. So again, it's more of a managed care model. And then Medicare Part D is the prescription drug plan. It's again gives them affordable drugs. They have to enlist in that, and there is a premium to pay. Medigap or Medisup plans are plans that help cover copays, deductibles, and coinsurances, which can get very expensive. And again, so this helps our seniors manage their healthcare costs. And Medicare has created 10 different Medisup plans that can vary state by state. So Medicaid is Title 19 of the Social Security Act. It provides health insurance to the medically indigent, meaning the poor. It is a welfare program that is administered at the state level. It serves 45 million low-income Americans. Medicaid spending varies based on the status of the U.S. economy. It is not a federally mandated program. However, all states have Medicaid except Arizona. So the states have to manage it, but they are not obligated to. PACE was authorized by the Balanced Budget Act of 1997. It's the program of all-inclusive care for the elderly. It's a comprehensive healthcare delivery system that is funded by Medicare and Medicaid, and it focuses on providing community-based care and services to people who would otherwise need nursing home levels of care. So again, trying to keep them at home and not institutionalize them, get them the help that they need. So the philosophy, of course, is that seniors with chronic care needs are better served in their community when it is possible. So keep them in their communities. The Children's Health Insurance Program was authorized also by the Balanced Budget Act of 1997 and codified as Title 21 of the Social Security Act. It's now called Children's Health Insurance Program, or CHIP. It's initiated in response to the number of children who are uninsured in the United States. It is also managed at the state level. And it covers children, obviously. Then workers' compensation, the employer is financially liable for the employees who become injured or ill as a result of working conditions. Workers' comp is a state-administered program. The employees may receive cash for lost wages, payment for medical treatment, survivor's death benefits, and indemnification for loss of skills. So if you lose a hand or lose something and now you can't do your job, you could get kind of a repayment for that. And then TRICARE, the U.S. DoD operates the Military Health Service System, which provides medical services to active duty and retired members of the armed services. As the number of active duty numbers increased, TRICARE was developed to respond to the growing needs of retired members, and of course active duty members too. TRICARE is regionally managed and is structured after managed care and coordinates the efforts of the Navy, Army, and the Air Force. In the Marine Corps, just in case you didn't know, their medical care is usually administered by the Navy. Indian Health Services. Indian Health Services provides comprehensive healthcare services directly to nearly 2 million Americans, Indian and Alaska Native tribes. So care is targeted to those population and managed again by the government. So it's federally mandated funds and services for them. Okay, so you can do the matching to match all of these different plans and what they are. And so the different reimbursement models, so historically providers set the rate for their services and the government and health insurance simply paid without question. So one doctor says, I charge $100 for a visit, another one says I charge $50, and whatever they bill for this, what they got paid. And so it was retrospective reimbursement or reimbursement after the fact, after the services were rendered. And so it provided little financial risk to the providers because they could just bill whatever and it would just get reimbursed. And so that is part of what caused this really huge increase in the healthcare costs, because they're like, oh, look at there. If I bill 100 or 120, they'll pay. So let me bill 120 or 150 and stuff and just get reimbursed. So let's run all these lab tests. I'll get reimbursed for them and stuff, and I'll make more money. And so, yeah, providers were doing stuff like that. So the most common type of reimbursement is a service benefit plan. So it's a prospective reimbursement method, was developed and used primarily by managed care organizations. So again, they're prospectively in advance paid X amount per patient in the plan to the clinic or to the hospital organization, whatever, and they have to manage their patients with those dollars, basically. The employer has a contract with the benefit plan and pays a premium for each of its employees, and the employees usually also pay a portion of the premium to the health plan and maybe a little copay, etc. In 1982, Congress passed the Tax Equity and Fiscal Responsibility Act and the Social Security Amendments of 1983 to manage medical cost. And so they mandated the hospitals to establish a prospective payment system to set reimbursement rates for certain conditions. So it was like, if you had pneumonia and you're hospitalized, you would get X amount of dollars. If you have to have knee surgery, you get reimbursed X amount of dollars. And so and they started grouping conditions in what we call DRGs, so diagnosis-related groups, and those represent similar diagnosis of diseases that are expected to have similar use of hospital services and therefore similar costs. And then the amount of reimbursement, it will set per discharge of a patient. So if they come in for, let's say have a hip replacement, the hospital would get X amount of dollars for the hip replacement, whether they use more or less of those. So again, this CMS, so Center for Medicare and Medicaid Services, reimburses hospital per admission and per diagnosis, which is based on the DRG, the diagnosis-related group. And again, it's a prospective payment system for hospitals, which is good because they can kind of plan their care. They know how much they're going to get for this type of disease or this type of thing, and so they can try to provide effective care within those cost parameters. And then there was resource-based relative value scale reimbursement. So this was developed to reimburse physicians according to relative value assigned to a service. So there's three components to that reimbursement: the physician work, the practice expenses, and malpractice insurance. Those are all costs that go into healthcare costs. And the Medicare would pay a flat fee for physician visit based on the Healthcare Common Procedure Coding System, which is used to code for professional services. It was implemented in 1992 and is basically the standard Medicare Part B reimbursement method to the clinic. So it's like, oh, if your diabetic patient comes in for its quarterly checkup and all that, you get X amount of dollars. That's what you get. And then you have ambulatory patient groups. So they were developed in the late 80s as a system of codes that explained a number and types of services used in an ambulatory visit. So this would be, again, clinics, walk-in clinics, outpatient type services, and that kind of stuff. They're similar to the DRG classification for hospitalizations, but the patients for APGs have similar clinical classifications, resource use, and costs and stuff. So it's just a different setting, but there's a lot of overlap there. Ambulatory payment categories, so they were implemented in 2000, and they were adapted from the APGs, the ambulatory payment groups, and it divides all outpatient services into 300 different procedural groups or classifications based again on similar clinical content such as surgery, medical, and ancillary services, and each APC is assigned a payment weight based on the median cost of services within the APC. So they kind of just gathered up information all around and say, okay, on average, this costs this much. So they took the average, the high, the low, the middle, all of it, got an average. So that's what they would, reimburse after they did the analysis and all that. The resource utilization groups is a prospective payment system for skilled nursing facilities. So it is used by Medicare for nursing homes and stuff. It provides a per diem, so that's per day, based on the clinical severity of patients. So the nursing home gets X amount of dollars per day to take care of their patient. And how to classify these patients by need, they used this resource utilization group. So it's a type of DRG. It was designed to differentiate patients based on their resource use. So how much time from the nurses they take, basically how much help they need, how much medications they need, and all that kind of stuff. And of course, as a patient's condition change, the rate of reimbursement changes. So if they start using more and more services, their reimbursements then would go up to the facility, obviously. And the home health resource groups was implemented in 2000, and it's a prospective payment used by Medicare, and they pay a fixed predetermined rate for each 60-day episode of care regardless of the services, and so that's for home health, right? All services are bundled under a home health agency, and it uses 80 distinct groups to classify the different patients' conditions and their need for home health and the amount of services to use from home health. And then a little bit about financial management. So the chief financial officer is who supervises the controller, who is in charge of the accounting and the reporting functions at usually the hospital or the organization. They may also supervise the treasurer, who is responsible for the payments, cash management payments, banking relations, accounts payable, all that kind of stuff. An internal auditor reports to the CFO, ensures that accounting procedures are performed in accordance with regulations and everything like that. And all of these positions ensure that the organization is focused on its mission and there's no embezzling and things like that going on. So as healthcare expenditures continue to increase, the major focus of the healthcare industry is cost control in both public and private sector. The retrospective reimbursement methods for healthcare services, again, meant that a provider submitted a bill to health insurance after the fact, and it was automatically reimbursed. That cost had no incentive to control cost, and that's what drove the cost of healthcare up tremendously. A few decades ago, we've been trying to clean it up since. The establishment then of this prospective reimbursement system for Medicare, so more of that managed care approach, was developed based on care criteria for certain conditions, regardless of the provider cost. It was an incentive, again, for providers to start managing how they were providing services and how much they were spending. All right, so if you have any questions, you can put it in there, and that is it for today. Thank you.